So I think we shall now go on to our third speaker, Dr. Charuta, who is a senior consultant ophthalmologist and specialist in cataract, refractive, and cornea services. She's also the founder of Oculus Regeneris Eye Care and Research Center. So on to you for a very interesting topic, AIOS, a guide for pre-op decision making in corneal surgeries.
Good evening to everyone, and at the outset I'd like to thank Dr. Chitra ma'am for this fantastic topic, all the organizers and AIOS for giving me an opportunity to speak on this dais. So I have no financial interests. In the session I'll be speaking on anterior segment OCT as a standalone modality for decision making, as an adjunct for the same. And I'll be also speaking a little bit about comparison of using the adapter attachment to a posterior segment OCT versus using a dedicated AIOS OCT device. And at the last, practical pearls for mastering the device that you have. Now, the OCT, when it is used as a standalone modality, it can be used to all the layers. So when used to assess the tear film, it has been described to be recording three parameters. That is the tear meniscus height, its depth, and area. Now, particularly, this is useful in quantification of a documented dramatic increase in the tear volume after applying maybe temporary plugs for dryness cases. So this has been described before. Now, in the case of another interesting application is primary pterygia, wherein elevation of the epithelium by a wedge-shaped mass, which is separating the epithelium from the underlying Bowman's layer, is seen. The interpretation of the anterior segment OCT showing residual can be used to predict the residual corneal opacity after surgery, and also can predict for difficult tissue dissections. Another important description is that the feature high resolution OCT features of flat bridging of the corneoscleral transition zone, reduced thickness of the pterygium head, and a greater degree of the corneal astigmatism, which is associated with scarring. There is another study also which has shown that increased Zernicke aberrations are found in the 5 mm zone of the cornea whenever the end of the pterygium exceeds 25% of the corneal diameter. Now, a very pertinent situation for all corneal surgeons is operating on a cataract in a post-keratoplasty patient. And the OCT image can show many details of this wound architecture. It can be helpful in planning location of the incision, whether it is clear corneal, limbal, or corneoscleral. Also, the axis of incision can be based on the angle status. It can also show us details of coaptation of the posterior wound. It will also tell us the residual pathology in the host, such as a PMCD, etc. These are three cases, clinical scenarios, wherein in the first case, there is aphakia and the host rim is very hazy. So AIOS shows disparity in the thickness of host and the donor, and can help in planning the incision and the direction of the keratome as well. Second one, you can see here, it's a case of keratoconus wherein the anterior surface in the OCT is very smooth, but there is significant distortion of the posterior ledge. The last one, we can see that there is 360-degree peripheral anterior synecdoche. In this case, they've also said that the radial scan or a global pachymetry and assessment of the raw maps revealed that an incision at a 45-degree axis would be helpful. Now, one of the most commonly used application of the OCT is for Descemet's membrane assessment. And it can be useful in diagnosing the problems, choosing a treatment, and also monitoring the outcomes. The image shows a residual Descemet's membrane in a case of a DMEC where there is detachment. Now, undoubtedly, it is also very valuable in assessment of the panis before planning for any surface surgery. And this is a study which has been done by Dr. Shanbag, where the role of OCT in decision making before SLET has been described. Now, this white bar below indicates a thickness of 250 microns. And as observed here, you can see the three images. The last one, the second case, B, is the one in which SLET alone is going to be enough for resolving the visual, for attending to the visual recovery of the patient. In the first case, as you can see, the thickness is too less, and the stromal support is probably going to be not enough for the stem cells to take up. In the case number 3 and 4, there is a tremendous amount of scarring below the pannus also, which is also going to predict difficult dissections. Now, another interesting application of corneal dystrophy OCT is in the management of corneal dystrophies, wherein much of the planning of the treatment is also based on the OCT scans. Now, I'm sure that in most cases, the presence of opacities in the dystrophy don't actually make it difficult to distinguish between whether it's superficial or deep. However, when we need to plan the mask, how much of epithelium needs, how much of the deposit needs to be ablated so that the epithelial masking can help us achieve an even surface, the OCT is definitely plays a major role. Now, post-endothelial keratoplasty, again, it's invaluable to diagnose graft dislocation, also to detect primary graft failure, crowding of the anterior chamber in case of thick grafts, encroachment of angles in secondary glaucoma cases, pupillary blocks, also to detect inadequate strippings and the residual host DM. So interestingly, there is also now, these are the routine applications which we have very commonly seen. However, they have now, there are studies which have predicted that post-endothelial keratoplasty, it is imperative to do OCT assessment in the immediate post-op, between 1 hour and 1 day post-operatively. Now, it is invaluable because the transient interface fluid at the end of surgery and in the first post-operative day, they have shown that it is very likely that such fluid is more likely to develop textural interface opacity, which we very commonly see, and leads to loss of a best corrected visual acuity. Also, large residual interface volume, thickness, and the thickness of the cornea at the end of the surgery are associated with graft detachment. In cases of post-deep anterior lamellar keratoplasty, the imaging demonstrates the detachment of the DM if it occurs, and also can demonstrate or confirm the reattachment in all angles after intracameral air injection. Now, pre and post hydrops. Now, what do I mean by pre and post hydrops? Very commonly, thus far, OCT has been used to demonstrate the cleft in the hydrops cases, and then selection of the cases as to which ones will benefit, like as in the first 2 images we see. This case has benefited from doing bubbling with C3 or with C3F8 or air. And in this case, wherein bubbling is probably not going to be useful, and one can go in for a primary graft directly. Now, what do I mean by pre-hydrops prediction? So, Fuentes et al. In 2015 described a series of cases wherein they had followed up serially all cases of keratoconus, and they have demonstrated that there is increased risk of hydrops in cases with anterior segment OCT findings of increased epithelial thickness, stromal thinning at the area of the cone, anterior hyperreflectivity or the Bauman's layer, and absence of stromal scarring. So these are 3 of their cases which they have beautifully shown all the features. That is, you can see the total thickness of the cornea is probably quite normal. However, the stroma is very thin, and there is a lack of scarring in all the cases. So these can be used practically in the outpatient clinic to use as predictors for hydrops. Another interesting application is that in keratoprosthesis, wherein the presence of retrokeratoprosthetic membranes can be detected on the ASOCT. A gap in the interface can also be seen, very easily visualized and located. Lack of the epithelial sealing around capro edge can also be detected. And an other anatomic changes which cannot be detected because of a failed graft, such as angle closure, peripheral synecdoche, iris and keratoprosthesis backplate touch, and graft host interface changes can be noted. Now, although thus far I have described the anterior segment OCT as the primary diagnostic modality, many times it does play an adjunctive role. And by adjunctive role, it actually it doesn't mean that it's playing a secondary, but actually a very useful role. Very commonly, we see detection of form frustrated keratoconus being missed on the topography maps, and the epithelial map and learning how to read the epithelial mapping is very pertinent now, so that we can appropriately select cases before doing laser vision correction. Another application is that before LASIK enhancement, because it is only possible to precisely measure our flaps. Sometimes cases are operated outside or referred, so the OCT gives us that advantage, and for predicting the residual stromal bed thickness after an enhancement procedure. Other application include diagnosis of the interface fluid syndrome and confirmation of resolution of the fluid in the same. This is a case of a keratoconus case with apical scarring and significant posterior keratoconus, in which the patient wanted to plan for a femtosecond bulk. Now, in this case, if we can see that only the pachymetry map alone will help us in planning the femtosecond bulk procedure, because only the peripheral 5 to 7 or 7 to 9 millimeter zones are showing enough thickness so that we can plan the ring cuts and the lamellar cuts appropriately. Another interesting application is that in keratitis, although personally I have never used it for this indication, but it has been shown to detect both fluid clefts to distinguish between necrosis and inflammation per se, and also to serially detect the resolution of edema in stromal keratitis cases. Now that brings me to the next part of my talk, wherein what is the difference between a posterior segment OCT, using a dedicated posterior segment OCT with the adapter, to a dedicated anterior segment OCT. Is it worth it? Now, posterior segment OCTs typically have shorter wavelength as compared to the dedicated AIOS OCT machine. And there's a little bit of more shadowing than the dedicated anterior one. However, it means that there's going to be no additional investment. And the image acquisition is much faster. Whereas in dedicated anterior segment OCT, although it gives an excellent view and a lot of clarity in the images, it does mean an additional investment, and the acquisition time is much slower. So at the end, I'd like to say that once you work with what you have, you can realize that there are a lot of details that can be observed. So try to, don't hesitate to image normal corneas. Keep the axis perpendicular when you're measuring anything, and make use of inbuilt softwares, and measure perpendicularly, and also expect that there is a learning curve in understanding each device and making the best of it.
Wonderful talk. It was actually, you covered all parts of it, and many of the questions which I had planned for you have been answered.
Okay, I escaped it.
That shows how well you covered it. But Dr. Rajesh, I'm going to ask you in this question, because all are institution-based expert panel, so I'm sure they have all the equipments, but even you would, I'm sure. But do you think a private practitioner actually needs to get an AIOS OCT? Does it become a differentiator in decision-taking in corneal surgeries?
Yeah, definitely. I think an anterior segment OCT for analyzing the cornea plays an important role, both in clinical decision-making, and patient education as well, because you're able to show to the patient in cross-section, let's say a DM detachment. If you show the patient an AIOS OCT and show them the problem, the subsequent management and the patient's acceptance of treatment becomes much more easier. Or like, let's say Hydrox, there is a break in the posterior area, or let's say you want to plan treatment post LASIK, you want to look at the flap thickness. So, it's very vital. And the modern anterior segment OCT is not just for cornea. You can use it for many things. It gives you mammography, it gives you, you can do epithelial maps with your anterior segment OCT. You can even look at the regional pachymetry on the anterior segment OCT, and it's quite comparable to the ultrasound pachymetry, which is better than some of the tomography devices, especially if patients have had like cross-linking or anything which induces a little bit of haze in the cornea. Then the pachymetry measurement by the tomography devices are not very accurate. So in that scenario, the anterior segment OCT is able to give you much better corneal thickness assessment. And surgical planning, it plays a major role. And I'm sure Namrata can share, having the intra-op OCT integrated into your microscope plays such a big role in a lot of surgical situations as well.
Yeah, I think it was very nicely covered. The whole talk covered almost everything. In acute hydrops, it plays a very important role because you can drain intrastomally also the fluid. In posterior keratitis, it plays an important role because you can see the posterior corneal abscess and you can see whether it is active or not. I think the greatest role is in our DMEC surgeries. I know Rajesh is very accomplished surgeon and can do without it. But I think Dr. Radhika will agree completely that we have become so dependent on it that, we become helpless without it. And it plays a very important role as far as the general ophthalmologists are concerned for cases of persistent corneal edema after phacoemulsification. Because all you need to do is do one AIOS OCT and see whether there is any DMD or not, and you can immediately address it. So I think on all these features, there are publications which are there, and everything was covered. I mean, and I think the greatest use is in the retained lenticule when you're doing a smile surgery and you can't make out where it is. So everything was covered really very well. I think it was an excellent talk.
Yes, truly. It was an excellent talk, and I think it becomes very important for us to understand all that needs to be seen in each of these imaging devices.
Can I make a quick comment?
Yes, Dr.
Yeah.
Ram.
So I think the role of ASOCT is very well established in the diagnosis of corneal diseases and also in conjunctiva, as she beautifully demonstrated. But I think the problem is when you have fluid or you have a solid structure or you have blood where it causes a lot of backshadowing and you really do not know what you're dealing with. The reason I'm saying this is actually recently we had a patient with dystrophy who also had a conjunctival lesion in the bulbar conjunctiva, which was gradually increasing in size. Really did not fit into any particular diagnosis, no trauma, no surgery. So we went ahead and excised it. And OCT only saw superiorly a bit of stroma. The lesion was occupying almost causing considerable backshadowing of the anterior stroma. And then when we removed it, we saw one of the very rare tumors, which is the COS tumor. So the limitation is definitely when you have something that is blocking the light, which is definitely difficult to resolve. So going back to the question that you asked about the different imaging modalities, different instruments, I think like you rightly said, only institutions will have access to all these things. But if you want greater tissue resolution, you probably want to use something that has better resolution. If you want to look at the lesion as a whole, then you want to use something that has reasonable resolution where you're able to see the back posterior extent as well. And if you really want to look at holistically the relationship of the lesion to the anterior segment, then you have SwepSource OCTs, which can actually give you all the details. So there are certain indications for using each of these appliances if they are available.
Yeah.